Alright, let's talk about screening for fetal chromosomal abnormalities. 1 out of 150 live births have some type of chromosomal abnormality. So the increased risk for aneuploidy, so for trisomy 21, for a 25-year-old is 1 out of 1,000. For a 35-year-old is 1 out of 300. For a 40-year-old is 1 out of 80. For all chromosome abnormalities, for a 25-year-old it's 1 out of 120. For a 35-year-old it's 1 out of 80. And then for a 40-year-old it's 1 out of 40. Most common chromosome abnormality is aneuploidy, and the most common autosomal aneuploidy in a liveborn, number 1 is trisomy 21, and that occurs in 1 out of 700 live births. Trisomy 18 is 1 out of 3,000, and trisomy 13 is 1 out of 6,000. Most common sex chromosome aneuploidy is Klinefelter 47XXY. It affects 1 out of 500 males. The only viable monosomy is XO. It occurs in 1 out of 250 live births. 2/3 of occult spontaneous abortions have chromosomal abnormality. Half of the miscarriages happen in the first trimester. 5% of stillbirths have cytogenic abnormalities. Between first trimester and full term, 40% of pregnancy end in miscarriages or stillbirths. Mitochondrial disease commonly affect tissues with high energy requirements, such as the CNS, heart, or muscle. What are the increased risks for Down syndrome, AMA, parental translocation involving 21, prior trisomic child or child with structural birth defects, up to 3% of structural defects are not associated with genetic abnormalities. If you have significant findings on ultrasound, cardiac anomalies, septal defects, tetralogy of Fallot, AV canal defects, duodenal atresia, positive screen result, triple X or XYY are fertile, not known to have discernible increased risk for having offspring with trisomy. So DNA, cell-free DNA testing derived from placental trophoblast undergoing programmed cell death. 10% of cell-free DNA in maternal blood can be fetal. Can be done after 10 weeks to lower rate of failure. Most sensitive and specific screening tests for common fetal aneuploidies. 99% detection rate for trisomy 21. 98% detection rate for trisomy 18. And 99% detection rate for trisomy 13. False positive rate is 0.1% with a positive predictive value of 80%. Compared to serum screening, the false positive rate is 5% and positive predictive value is only 3%. False positive cell-free DNA can occur from confined placental mosaicism, which is associated with increased risk of fetal growth restriction. The positive predictive value is lower for younger patients due to lower prevalence. This is the only test that can detect sex chromosome abnormalities or aneuploidies. If patient had organ transplant, this can't use this test for sex aneuploidies because it can the donor organ can influence the test. Incidental finding affecting the patient during a cell-free DNA test, the patient's own chromosomal aneuploidies or mosaicism can be detected, or if the patient has some kind of sex chromosome aneuploidy. In a vanishing twin case, cell-free DNA should not be performed due to high risk of aneuploidy in the non-viable embryo. Microdeletions can be detected, however, due to low prevalence. Most positive results are false positive, so diagnostic testing should be done. Microarray abnormalities are common in young adults, so these patients, if they want to know more about, if they want to test for microscopic chromosomal changes, they should consider microarray, which is you can do it with CVS or amnio. Even if cell-free DNA is negative, you can still have microarray abnormalities. Sequential screening can identify more chromosomal abnormalities, including other aneuploidies, mosaicism, large deletions, or duplications. Cell-free DNA can be used as an option for people wanting to avoid diagnostic tests. The false positive, it can contribute to false positives, such as due to mosaicism, vanishing twin, or malignancy. On the topic of malignancy, this does complicate about 0.1% of pregnancies. It is defined as malignancy during pregnancy up to 1 year postpartum. If multiple aneuploidies are identified, the incidence of occult malignancy is about 20%. Majority of them are hematologic. Minimum fetal fraction needed is 3%. However, some have lower fetal fraction, such as people greater than 250 pounds, IVF pregnancies, maternal drug exposure to heparin. Test failure is associated with increased aneuploidy risk. It is about 3% aneuploidy rate versus 0.5% in a group with no failed test. 13 and 18 have lower fetal fraction, therefore higher failure rate. The test can be repeated and the success rate is around 80%. So what are some of the analyte testing? You can do first trimester screening tests between 10 to 14 weeks. You can do NT plus PAP A plus HCG and AFP. Increased NT greater than 3 millimeter is independently associated with genital heart defects, abdominal wall defects, diaphragmatic hernia. Even when the genetics is normal, fetal echo should be considered. Quad screen, 15 to 23 weeks. So you have the HCG, AFP, like earlier. You add inhibin A, E3, and maternal factors. The Down syndrome detection rate is 80% with 5% false positive rate. Penta screen, don't worry about it. So integrated screening versus sequential screening. Integrated uses should be used only if ultrasound is not available, and the first trimester screen is not reviewed until the second trimester screen is done. Sequential will have a stepwise strategy where if the first trimester screening is positive, then we can use diagnostic test or cell-free DNA screen. Cell-free DNA can miss some chromosome abnormalities and delay diagnosis in this case. Contingent, we can stratify patients into low risk, immediate risk, or high risk. Immediate risk can do second trimester screening. High risk is offered cell-free DNA screening or diagnostic testing. Ultrasounds for screening. So when NT is used alone for trisomy 21, the detection rate is 70%. It is helpful in multi-gestation where serum screening might not be as accurate. Absence of nasal bone or absent or reversed ductus venous Doppler increased risk for aneuploidy, cardiac and neuroanatomic anomalies commonly associated with chromosomal anomalies. Trisomy 21 soft markers. So for trisomy 21, only 30% of fetus have a major ultrasound finding. Some of the soft markers are echogenic intracardiac focus, thickened nuchal fold, renal pelvic dilation, echogenic bowel. For 18, soft markers include choroid plexus cyst. This can be seen in 2% of normal population. Trisomy third trimester follow-up indicated if isolated renal pelvic dilation, echogenic bowel, shortened humerus or femur. Like I said earlier, increased NT greater than 3 millimeter is associated with congenital heart defects, abdominal wall defects, and diaphragmatic hernia, even when the chromosome is normal on diagnostic screening. Abdominal wall defects. Cystic hygroma. This is basically the extension of increased NT along the fetal spine, associated with 50% likelihood of fetal aneuploidy, Most common is 21, XO, and 18. Genetic anomalies occur in 29 in 30% of fetuses with normal karyotype. Cardiac anomalies were the most common, followed by urinary, central nervous system, and body wall anomalies. Spontaneous prenatal loss occur in 40% of these fetuses. 85% of fetus with cystic hygroma will have abnormalities. Screening for twins. There's no test that's better for twins than singleton. First trimester combined screening in twins have 90% detection rate and 5% false positive rate, which is similar to singleton. Higher rate of test failure on cell-free DNA. However, if the results return, rates are similar to singleton. Screening after PGT. Screening is the same regardless of previous pre-implantation genetic testing. So low PAP, less than 5 percentile, is highly associative with FGR, preterm labor, PIH, placenta abruption. This is something secreted by placenta-syncytial trophoblast. Inhibin A is produced by the corpus luteum and placenta. If high, patient is at risk for preeclampsia, preterm birth, IUGR, and fetal death. Alpha fetoprotein is from the egg yolk, yolk sac, fetal liver, and GI. So if it's high, there's a risk for neural tube defects, GI problems, renal problems, placenta accreta, gestational hypertension, preeclampsia, abruption, and pregnancy loss. If low, risk for miscarriage, preterm delivery, fetal demise, macrosomia, aneuploidy, and the unconjugated estrol. If low, then IUGR and early pregnancy loss.